How are you?
Stressed.
You've been back in class for a couple weeks now, or just
All year.
all year long?
You got
Never
lunch
ending.
break.
Well, good. Well, my name is Tracy Jalmstead. The H is silent. It's a Norwegian name, so I apologize right off the get-go. But originally I'm from North Dakota. My wife went to OU, and Mr. McNeil was her the director of her program, where she went to OU, and she's a PA as well. About 5 years ago, we decided to move back to Oklahoma and come home, because this is where she wanted to be. She didn't like the cold in North Dakota, so we moved back, and we've been happy and busy ever since. So when we moved back to Oklahoma, I opened my own practice. I was an employee of a hospital for 10 years up in North Dakota, and it was just kind of time to leave, time to do something different. So I opened my own practice up here, and now I'm on staff at Mercy and Baptist and Deaconess and Summit, and I kind of go all over the place, and it's kind of fun to not just be at one facility. So that's me. Okay, we'll kind of start out talking about diabetic foot. There's lots of different things that we do, but I usually start here because people always ask me, do you see people that have diabetes and diabetic feet? And the obvious answer is yes, we do. We see quite a few. So we'll kind of start here, and I have a couple of questions just kind of mixed into this lecture so that we can, at the end, we'll kind of go through and answer some of those questions too. And if you want to keep a piece of paper as we come to those questions, you can kind of jot down your answers and guesses as we go forward. So about 30% of my practice is patients that have diabetes. So 30% of my patients that I see annually have diabetes. The American Diabetes Association recommends that people that have diabetes see a foot specialist, a podiatrist at least once a year. Just like they recommend that they see an optometrist once a year. Just like people with diabetes should see a nephrologist once a year. So it's something that the ADA recommends. When I see these patients that have diabetes, we always approach them systematically. I do the same thing every time to every patient, that way I never miss anything. And then what I do is try to stratify whether they are high risk for losing a toe or losing their foot, a high risk for amputation or having foot problems. And I tell people that. I just say you're high risk, you're low risk, you're moderate risk. And based on those risks, then we see them back accordingly. So when I see people and I'm doing a diabetic foot exam, I hit 4 major components. Yes, I could do this in my sleep. I think I've done this 15,000 times or more. But I do a vascular exam, neurologic exam, a derm exam, and a musculoskeletal exam. We'll kind of roll through each one of those and throw in a few questions. I got lots of pictures too, because I'm kind of a picture guy. I don't know if you guys like looking at nasty pictures or not. So when I see people, first thing I do is I'm talking to them and talking about their diabetes and when they last saw their regular doctor, what's their A1C, when did they last check their blood sugar. I have my hands on their feet and I'm feeling their pulses right away. So I'm feeling DP and PT pulses. We can measure those quantitatively with a duplex Doppler or an ultrasound. So patients, if they come into the hospital and they have questionable vascular disease, I'll get a duplex Doppler or an arterial ultrasound of their leg. And but in clinic, I'm just basically label them as being absent or present, palpable or non-palpable. I don't get real technical in clinic, but I always talk about their edema too in the vascular portion of my exam, whether it's +1, +2, +3. What does +1 pitting edema signify? Anybody know? So if I'm pushing on their tibia, on the front part of their tibia, and I'm trying to gauge their pretibial edema, and if they have 10 millimeters of depression, if I can push in 10 millimeters, 1 centimeter with my thumb, what is that? +1, +2, +3, +4? +2. So 5 millimeters of depression signifies +1. 10 millimeters +2, 15 millimeters +3. When you think about it, that's a lot of swelling. That's a lot of edema. Okay, you can start to get +3, +4 pitting edema. People start to develop ulcers on their legs, big open vascular lesions on their legs. Okay, when that happens, the best thing you can do for those ulcers is to squeeze that fluid out. So use compression on people that have venostasis ulcers. So there I am with my fingers, my hands right there, checking the DP pulse, a dorsalis pedis pulse. And that's our PT pulse right behind the ankle, midway between the medial malleolus and the Achilles tendon. This is kind of just a rundown of the vascular network as it flows down into your foot. So, superficial femoral comes down to the anterior tibial. There's also a perineal vessel as well. You cannot palpate a perineal vessel. There is one that comes down in the foot. There's three main arteries that come down into your foot. The perforating perineal artery is one that you cannot feel. Okay? I've never felt it in 15 years, let's say that. So, here's somebody who has venous disease, varicose veins, and here's what they look like. I'm sure you guys all know what these look like. Compression is the main treatment for this. Here's we have a DVT, okay, and this person has a blood clot in their calf, and that's exactly how they present. Usually it's red, hot, swollen, pain. They don't remember any injury or anything like that, but there's an obvious difference, and that's why you always look at the other leg. You look at both legs, not just one. If they're coming in for their left leg, definitely look at their right. Are they the same or are they different? So here's, I see a lot of these people that come into my office. You can see that a little old lady wearing her shoe. She can't fit into her shoe because she has a muffin top shoe, right? She's got part of her foot is so swollen it kind of sticks out the top of her foot. And she's got a dress on that goes all the way down to the floor, and she's coming in for a diabetic foot exam, and she just wants me to look at her feet. And I always have to push somebody's dress up a little bit, and then we find, okay, we've got these vascular lesions on their legs, so her foot is connected to something, right? It's connected to her leg, and it's connected to her body, obviously. So I always do more or less a lower extremity examination, not just a foot examination, or not just looking at their toes. But you can see already, she's probably got, based on how her socks look, probably 2 to 3 plus pitting edema, and she's got vascular lesions on her legs already. So what percentage of people that have diabetes end up having an amputation? Write it down. 5%, 10, 20, or 23.8%. What's your guess? Don't say it out loud. We'll answer these questions later on. Next part of my exam. So after I'm done feeling their pulses, I get out a little monofilament. You guys seen one of these things? It's a Semmes-Weinstein monofilament, or the name for it is a 10-gram monofilament. There was a study done that shows that these things, they last about 10 times. When you use them 10 times, that filament develops a bend and it doesn't work anymore. So it's time to get a new one. Okay? I don't do that. I've had one for a long time. I use it on a lot of patients. I try to throw mine out at least once a month. Luckily, I have a lot of reps that come by and they give me hundreds of them. So, but the 10-gram monofilament. So there's 10 different points on a person's foot that I touch, and I do each foot. So I do 10 on the left, 10 on the right, and I go through and I also check their deep tendon reflexes. Places that I touch on their foot, you can kind of see the different locations. And this is a chart that I actually use in my office. And usually when I go through, I'll put a plus, or if they can feel it, or a minus in the circle if they can't. And these are the points that I touch. So first, third, and fifth toe. First, third, and fifth med head, usually medial and lateral, because there's 2 nerves that go to those areas. And then their heel, and then once dorsally. I don't go here and here up here. I just go dorsally right over the top of that between their first and second heads. So I only do 10 points, and that's what's recommended. There are a couple of studies that have come out that show that if they can feel it underneath the first med head, really the rest of them really don't matter. Either they're neuropathic or they're not. And if you were to only test one spot, and that would be my suggestion to you, if you have a monofilament, you want to do all 10 of these spots and be complete, and you're doing diabetic foot exams and wherever you're practicing, yes, you can hit all 10 spots and you look like a hero. If you just have a monofilament, you're seeing these people and you just want to hit one spot, the biggest place to hit would be underneath the first metatarsal head. If they feel it, I would say more than likely they don't have neuropathy. If they don't feel it, then more than likely they do. What if they feel it on the right and they don't feel it on the left? Does that signify neuropathy? Is that significant for neuropathy, do you think? Neuropathy is typically bilateral. It's both feet at the same time. It's peripheral. It starts peripheral and it's bilateral. So if they can feel one and not the other, a lot of times I'm thinking, do they have a pinched nerve in their back? Do they have a perineal nerve atrophy? Do they something else going on that would signify a nerve disorder that's not neuropathy. So different things that I check. I do my, usually my monofilament testing. Other things that I do are proprioception. Where I bend the toe up and down, I'll go up and down like this, and then I'll stop up. Usually I'll shield their eyes and I'll say, okay, is your toe up or down? And I'll say up or down. Go back and forth, down. That's another way of testing proprioception. Vibratory is actually the first thing that they lose. Okay, so not just with that monofilament when you touch people. People usually, if they can feel if you touch, actually they might still have some neuropathy. The best way to test for that is with a tuning fork. So I use a tuning fork sometimes. I'll wrap it on my heel, I'll touch their big toe, and I'll feel on the other side of their toe. And when I can't feel that vibration anymore, that means that obviously if they can't feel it, or if they stop feeling it before I've stopped feeling it, that's evidence of neuropathy as well. So vibratory is a much more sensitive test. You can do a dull sharp test as well. You can do a two-point discrimination. The gold standard for testing for neuropathy is a neural conduction velocity test. So these are all pretty subjective tests with the exception of the neural conduction velocity test. Neural conduction velocity test, which actually measures wavelengths and how fast the nerve conducts a stimulus. So if there's any question, I was over at NCV. Derm exam, yeah, I look at their feet. Yes, I look in between their toes. I look at the color of their skin. Is it normal and consistent with the color of their skin on their legs, everywhere else? I know hair growth. People that have vascular disease tend to lose the hair on their toes first, so I document that. Nail quality, do they have fungal nails or ingrown toenails? Are they normal? Temperature, texture, pressure points, calluses, things like that. Smelly feet. There's a medical term for smelly feet. You guys know what that is? Okay. Look it up. All right, so here's just a lot of things that I see in clinic, just some toenail deformities. If you can imagine your grandparents have difficulty bending over to pick stuff up, and all of a sudden they got these kind of toenails. How do they cut them? How do they get down and physically bend over and cut them? You can see one of them, the big toe, looks like it has an ingrown toenail. It's curved almost into a, I would even say like a three-quarter circle. Obviously, if they try to cut this themselves, they probably be able to cut themselves. So Medicare actually pays for this. For people that have diabetes and have evidence of neuropathy, they actually will pay for people who have their toenails cut. And there's actually a CPT code. It's a surgical code. And I don't like to do a lot of this stuff because I do have surgical training, and I like to do surgery, real surgery, not just trimming toenails. But there's some podiatrists that's all they do, and they make a good living just trimming toenails. But it is a covered service, again, if they have diabetes and if they have evidence of neuropathy. If somebody comes in and they have this kind of toe and they have no other medical issues, they don't cover it. So insurance does not cover it if they don't have any other medical issues. So here's a fungal infection of the toenails. You can see how toenails are thickened. Obviously, they can't cut their toenails anymore. Either this person can't cut their toenails, but their skin looks pretty good, doesn't it? So this is a person that, I believe they did have, I don't think this person had diabetes, who just had fungal toenails and wasn't able to cut their toenails. That's another angle. It's quite fun. So here's post-debridement, post-cutting. Here's the ingrown toenail. This is what I typically see in my office. Both sides of the borders of the toenail are erythematous, edematous. There's drainage, pus, calluses. So here's a skin lesion. What is a callus actually? Why does a callus develop? You guys know? Pressure, right. How much pressure? I mean, what do they need? Nikes? Do they need Adidas? Reeboks? What do they need? They have pressure, right? So what can you see in this person's foot right now that you're looking at the bottom of your foot? What do you see that jumps out at you as being a reason why they might have pressure?
Deformity?
Yeah. So they got toes drifting that way, so they have a bunion deformity. So if they have medial prominence here, here's where they're developing a callus right here. A callus will increase the pressure in that area by about 30%. That's why people get sores. So when I look at these, I used to think calluses, corns, what's the big deal? They're gonna develop an ulcer here, one likely, that should be I call it now a pre-ulcerative lesion. That's an ulcer developing right there. Here's another one right here. Why do they get a callus right here? So you can kind of see their toes are contracted up here. But their toes are contracting. A person's toes will contract typically due to a bunion. So the bunion is the primary problem. A lot of times people will come in and they'll complain about just their toe. You know, my second toe, it rubs on the inside of my shoe, I get this little corn on the top of my toe. And you look at their foot, and, you know, you see this, and you go, holy cow, you got a huge bunion. We got to get your bunion fixed to allow your toe to come down, and it ends up being kind of a major thing for people because just they have a corn on their toe. So, but people that have these kind of calluses, they will ulcerate someday. They will open up, and that will lead to an amputation if it's not corrected. So, for people with diabetes that have things like this, that have issues like this, can I do surgery on them? If they have diabetes, can I do surgery, or am I not supposed to do surgery on anybody with diabetes? Would I fix this? If they're in good control of their diabetes, if their hemoglobin A1C is less than 8, and they see their family practice doctor, internal medicine doctor, endocrinologist regularly, if they are a good candidate for surgery, then yes. In fact, I almost encourage it. I recommend it. Because you can prevent amputations just by correcting the deformity before their diabetes gets out of control, before their vascular situation gets worse, before they have neuropathy, and end up with an amputation. So here we have another callus. Oh, just a callus on the big toe, doesn't look real scary. There's kind of some kind of dark discoloration, you know, in the middle of that callus. Again, what's the big deal about calluses? If you look at the top of her toe, oh boy, there's a lot more going on there maybe than what meets the eye. Maybe it's not just a callus. So I get my little 15 or my 10 blade out and I go scraping away on that callus, and we find that underneath that callus, what does she have?
Ulcer?
Yeah, she's got an ulcer. So right now you can see just by looking at her toe as she's sitting there, her toe is contracted, right? So when she walks, she has pressure because of her contracted toe. When she walks, she bears weight here, and she's got a callus here, right? And because her toe is contracted, she bears weight here, and then she gets a callus here too. So this one started to ulcerate and open up because of that pressure increase in that area. So we got a situation on our hands already where we need to debride that and clean it up and try to get her into some diabetic shoes, some offloading inserts, and try to prevent her from losing her toe. What do you see there? Any guesses?
Blister?
Blister? Give you a guess. Eczema? Could be. Any ideas? Any other ideas? So this doesn't have anything to do with diabetes. What if I said this was in a, and it's not, but what if I said this is in a 15-year-old kid? Give you a guess. Anything else? We've got bacteria. He said some bacterial things. He said some fungal things. What else? Anything viral? Anything viral going on there? Influenza. That's a plantar sport. It's a mosaic verruca plantaris, okay? So verruca plantaris, plantar sports are a virus, right? An HPV virus, right? So this is one of my favorite patients. Comes in with just an ulceration on the bottom of his toe. I think I got more slides in this guy too. But so ulcer there. Obviously he's lost his big toe. He's lost his fourth toe over here. Let me see if we got more slides in this guy. Yeah, okay. So this is one of my favorite patients. Comes into the ER. Anybody see what time that is?
5:30
Yep.
a.m.
So he's this is one of my diabetic patients, kind of a real young, I think he was, yeah, he was my age. Alcoholic, type 1 diabetic, has this going on in his foot, ulcer, an open area on the top of his foot. Doesn't want to come in because he knows he's going to be hospitalized. He knows he's going to lose a part of his foot, and goes to the bar and has his fill and comes into the emergency room at 2 in the morning. They call me at 3:30, and he's septic. He needs to go to surgery right away, and obviously his foot is prepped and he's ready to go for surgery at 5:30 in the morning. So podiatrists are on call, and we do see some sick patients, and we get called in the middle of the night. It's not, I thought it would be a little bit more clinic work and easier stuff, and it's not. More than I bargained for, but, so this is what he came in with. It's a big open area in the middle of his foot. Again, he's missing his big toe, he's got a second and third toe and fifth toe, and now he's looking at obviously more amputation. Here's an example of wet gangrene, so you can see that there's a necrotic toe, and it's obviously draining. There's pus and infection. This person obviously needs something surgical done. This does not get better. This only gets worse, and this only ascends. So if you see something like this, this is a surgical emergency. This is something, if it comes in the emergency room at 10 o'clock at night, they have to call somebody, and it has to be jumped on right now, okay? It's not something that can just wait until the next day, or, whenever Dr. Johnston wants to come around on this patient. This person needs to be seen right away and taken to the emergency room, or this just continues to ascend. What's that? So this is my same patient. This is the same guy. So he obviously on the other foot, you can kind of see he's lost more parts of his toes. He lost more over here, and after he had this done, this is called a transmetatarsal amputation. He had a dressing on his foot. He went home, and I didn't see him for like 3 weeks. I was like, well, where'd this guy go? And we called him. He doesn't want to come in. He's doing his thing, and comes in with this. So there's a medical term for this too. Anybody know what it is? We can look it up.
Infestation.
So there's a medical term for maggots. It's never a good thing when the emergency room calls you and the nurse on the phone is like, you need to come and see this. I've never seen this in my life. And I think, oh no, what's going on? Luckily, I've seen this quite frequently. I did a rotation in Tennessee, and I saw this like 3 times a week. It was like every week people in Tennessee had this. Going back to North Dakota, never saw this. Down here, I've probably seen it probably once every 6 months. So obviously maggots, fly larvae, if they can lay eggs on an open wound, this is what happens and develops. And this smells terrible. This will clear out a room. A lot of times it's the cleanest wound you've ever seen. It looks fantastic when you get those little suckers out of there, but a lot of times they'll tunnel and they'll go into a foot. They create little cavities and things like that in the person's foot. So this is the same thing. This needs to go to surgery. It needs to be cleaned and flushed out and debrided. We need to get those out of there because those will start to eat into that bad dead tissue as well. So, after debridement, that looks pretty good, doesn't it? So this is after surgery, cleaning it up. There was a little defect right here where they had created this tunnel and kind of gone down into the tunnel this summer. Once we got them all flushed and cleaned out, they looked pretty darn good, and this guy actually went on to humans. So the maggots did a good job.
How long did it take you?
What's that?
How long did it take you to get off them now?
Not long. I mean, probably 15, 20 minutes. It's a short surgery. I use a pulse lavage, one of the squirt guns in surgery, and I flush 3 liters of fluid through it. And if I have to make an incision and open up and find out where they're tunneling to. If they get into the bottom of the foot, I don't know how much anatomy you guys do, but there's 4 layers of muscles on the bottom of your foot. So if they get kind of in and around and underneath the metatarsals and into kind of that arch area of your foot, then they can start to get into all these different layers of muscle, and a lot of times it's hard to find those little suckers roaming around in there. So you never want to close up over something like that, so it'll just fester. So it can be just a quick cleaning, and sometimes it's a major undertaking and a huge dissection to get done. Never fun. Okay, another question. Unmanaged diabetes can lead to all of the following foot problems except what? Ulcers, onychomycosis or fungal toenails, fracture, ingrown toenail, numbness. Unmanaged diabetes can lead to all of the following foot problems except. Write it down. Okay. Next part of my exam, so I'm testing just musculoskeletal system. I'm testing for muscle strength, range of motion, symmetry, whether they have good muscle strength on both sides. And then, of course, I'm evaluating for deformities like bunions, hammertoes, flat feet, and flat arch. Okay, bring those kind of things into my notes. I would say people with diabetes that have flat feet tend to do better than people that have high arched feet. Just because when you have a real high arch, most of your pressures are on your metatarsal heads and your heel. So people will tend to either ulcerate at their heel or their met heads. If they have a flatter foot type, then a lot of times their weight is more evenly distributed on the bottom of their foot, and they're easier to get a diabetic insole into their shoe that can offload and take pressures off their foot. So I always get really nervous when those diabetic people come in and they got these real high arches and then neuropathic. That's like a bad combination. Those people tend to ulcerate. So here's another, same thing, bunion deformity. Do I take this lady to surgery if she's got diabetes? Yes, if she's in good control of her diabetes, her A1C is less than 8. Fix that. Correct her toe problem. Prevent calluses down the road, prevent ulcers, amputation. So preventing problems down the road. Hammer toes, so here's another lady who just has contracted lesser toes. She's got something else going on here in her foot. Those are, if you look at her feet, look how thin her skin is. She's got all these little vascular lesions and little vessels, obviously PVD. Look at her toes though. You can see this little callus right in the middle there. There's an ulcer right in the middle of that callus, right there. And I put a little metal probe in there and I'm tapping on bone. I'm just tapping right on the bone right there. So she's got an ulceration that probes right down to the bone. Well, first of all, going back, what other kind of problem would you guess that she had just looking at her feet?
Stupid.
What if I told you that I looked at her hands and her hands are just as bad?
This contraction.
Right. There's another difficult one to treat. Somebody who has diabetes and rheumatoid arthritis, because what is she taking? Prednisone and methotrexate. They're trying to suppress that disease. And then her skin is just thin as can be. And she's got all these toe deformities here. And, somebody else like family practice is seeing this and, kind of keeping an eye on it, or she's at the wound care clinic. This lady needs to be offloaded. She needs to get pressures off the bottom of her feet. I think she was kind of past the point of ever fixing this deformity too. But now, she has an ulcer that probes to bone. If I can touch bone, if you can see bone or touch bone, what is your guess is the percentage of the chance that that bone is infected? Would you say it's 50%, 70%, 90%, 100%? What would be your guess? If you can see it, or touch it.
50.
Okay, 70? 80? 50? 90? It's actually 93. 93% chance, okay? So really, if you can see bone or touch bone, you gotta be thinking osteomyelitis, bone infection, and of course we see that all the time. This is an EO 82. I think she was 83 or 85. Rheumatoid arthritis, had it for 60 years. That's her other foot. So, obviously lots of digital deformities, just a real, high likelihood of developing ulceration and having problems. So this person just very much needs a custom molded shoe, a custom molded insert, and they need to be offloaded so that they don't develop sores in the bottom of the feet. Yeah, see all those pressure points down there? Like our first med head is almost coming out right out of her skin. Our other toes are just contracted. So lucky toe syndrome, similar to a bunion deformity, but if you can cross your toes like that, you're obviously very lucky. So bunion, hammer toe. If a bunion gets bad enough, I guess I should explain bunions too, maybe we'll get to that. But a bunion is not just that she has a bump right here, right? I mean, there's just not a bump that's growing, and she gets kind of a big knuckle right here. Some people that happens, but most of the time what happens is your toe starts to deviate too. So when your toe is deviating, it's subluxing at this joint, it's dislocating at this joint right here. That's what a bunion is. We just went and shaved off the bump. Did that straighten out this business out here? No. Shaving off that bump does not correct her toe problem. Okay. So we have to do almost a joint realignment. So bunions are probably one of the hardest surgeries that I do, to be honest with you, because you're trying to balance this toe on the end of that first metatarsal. They're not easy. Anybody who says so, I have tons of x-rays, I have a whole bunion presentation to go over and talk about things. But what happens is your toe starts deviating, it starts subluxing or dislocating at this joint, and then what happens is second toe has to make a choice. I need to get out of the way here, because big brother or big sister is getting in my way, getting in my business. So a lot of times second toe will go up, sometimes big toe goes over the top, and a lot of times then third toe and fourth toe, they start to do what big sister second toe starts to do. So they start to kind of move out of the way, and out of the way as well. All right. We asked this one, didn't we? Okay, what is the number one modifiable risk factor that doubles, okay, we didn't ask this one. But what is the number one modifiable risk factor that doubles the risk of heart attack, stroke, amputation in the presence of diabetes? One more time? No. Smoking, yep. Good. Good, I actually, I was gonna say, write that one down, I think you got it right. So, cases, okay. So, here's another one of my patients who comes in, has an ulcer that's kind of started to invade the top of their foot. More than likely, this started as a little toe, just gangrene or necrotic little toe, and then if we don't manage that quickly and efficiently, that starts to ascend, and this goes up into their foot. Now they have an ulcer that involves the top of their foot. More than likely, somebody like this will probably lose all of their toes, even their good toes, all the way across this way here, because you got to get up with better tissue, for vascular tissue. This picture, dude, to me, it speaks 1,000 words. Again, I'm doing surgery on this, and the circulating nurse who's in the room, where's she at? She's off in the corner all the way. That's disgusting, and she's almost hiding from it. And that happens all the time. Yeah, she just about ran away, ran out of the room when she saw it. So I unwrapped the dressing and she ran. But you can see how bad that is, the tissue devastation, and you know, how do you just take that fifth toe and even try to get that closed? There's just not enough skin coverage to try to get that closed. That's what it looks like on the bottom. On the bottom, it doesn't look that bad, just fifth toe, but obviously there's some redness higher up into the arch of the foot. Close up. But that's all they lost. So we did a debridement of that area and took the fifth toe and cleaned everything up. And the rest of the tissue is pretty vascular. So looking at that, you'd say, I mean, I even look back at this too and think, that's amazing that they kept the rest of that stuff. And what I did was clean that up, flushed it out. We had a wound over the top of the foot, and then I took a skin graft called an aplograft, and I put that over the top. And I think we ended up doing 2 of those aplographs. And look at that. That looks pretty good. That looks pretty good again. And it just got better and better and better, and they healed up. And they only ended up losing that one little pinky toe. Now their foot is forever changed. It's forever different. So their weight-bearing portions on the bottom of their foot are not the same. So what are they going to develop? Lots of calluses. Yep, so they need to be in a diabetic insert, diabetic shoe forevermore to protect their feet from breaking down. That's my son. This is cool. All right, heel ulcer. So here's an ulcer that we can see. This is nursing home patients, people that are bedridden, that are in bed all the time. This is on the back of the heel. Right here, we got, what's this red part right here? and the bone. That's your heel bone right there. Here's the fat pad down here. What's this up here? Achilles tendon, right. So if you can see bone, you can see that tendon starting to necrose, as is that fat pad. What do we know about that? You can see bone, touch bone, look at bone. Right, so more than likely this person has calcaneal osteomyelitis, okay? So same thing, this needs to be cleaned and flushed, debrided. Charcot, do you guys know about Charcot? Have you ever heard that term? Okay. What is Charcot arthropathy or Charcot deformity? Charcot is a French word that, another name for it is diabetic neuropathic osteoarthropathy. That's a mouthful, obviously, so it's easier to say Charcot. But it's a fracture of the foot. So if you can't feel your foot and you're running across the lawn out here trying to catch up to your buddy to go get lunch, and let's say you stepped awkwardly and you broke your metatarsal, but you can't feel your feet because you're diabetic. And this happens all the time. Well, it didn't hurt. It didn't hurt at all. I just kind of stepped awkwardly and I got home, my foot was swollen. Huh. Swollen, red, bruising. What does that sound like? Could be a fracture, right? But it doesn't hurt. A lot of times, oh, maybe you sprained something or bruised something, or, just keep an eye on it and see if it gets better, right? And then they come in and they have this fracture. We'll get to some x-rays of Charcot. You'll be able to see it and you'll go, oh my gosh. But we see that all the time where people come in with a red hot swollen foot and, nope, didn't do nothing. Feel fine. Doesn't hurt. I think I sprained something. Just coming in to have it checked out. Or maybe it's been going on for 2 months. And they come in and they say, well, it's been going on for 2 months, but it doesn't hurt, so I didn't think it was a big deal. If you see an ulceration on the bottom of a person's foot that's right in the middle, this is kind of no man's land. When you stand on your foot, you bear weight typically out here, toward your med heads, and your heel, right? So if you see an ulcer kind of right in the middle of their foot, is there a bone that protrudes right there? Is there any kind of bony structure on the bottom of a person's normal foot that should be there? No. So there is something that's causing that sore to be there. So if you see an ulcer kind of in the arch area or in the middle of a person's foot, you should be seeing red lights, like there is a major problem going on here. And like with this guy, this picture again speaks 1,000 words. Let's see, he's sitting there like this, like, I've seen my family doctor for this ulcer, I've seen the wound care clinic, I went and saw an orthopedic doctor, and now I'm coming to see you. What are you gonna do for me? Nobody's done a darn thing. I still got this sore on my foot, and it's been there for like 2 years. What are you gonna do for me? Okay, so he's mad. He's like, why do I gotta be here? You're not gonna fix this anyway. So he's got Charcot as well. We'll get to some x-rays of Charcot. Question, what percentage of people with diabetes have an amputation? The answer is 5%. Actually, it's less than 5%. When I was working up in North Dakota, I worked on a Native American reservation, and they've never had a podiatrist before, and their amputation rate was almost 35%. It was unbelievable how bad it was. And they just would never send people in to get treated for diabetic shoes. So once I got on board, and this is not like tooting my own horn or saying what I did, but just what can happen if you actually have a foot and ankle specialist and implement a diabetic shoe program and do some different things. But it went from like 35%, I think there were something like 200 amputations in just this small little clinic, this small little town of less than 10,000 people in 1 year. And I was there for 4 years. And the next year I think we got it down to like 50, and the next year it was down to 20. And then my final year there, they didn't have any amputations. And we implemented a diabetic shoe program. And of course, they were federally funded. They had lots of funds for things like this. But we implemented a diabetic shoe program. We implemented a wound care center so that people, when they had wounds like this, they could come in and be seen and treated. And what else did we do? Well, we just had a diabetic foot program going on, and really got things up and running, and we just nailed it and got so that there were no amputations in my last year, and that was a really good feeling for me. And then funds ran up and it was just time to move on. They let my contract go because they ran out of funds. So, but that's the way things go sometimes. Next one, unmanaged diabetes can lead to all the following foot problems except ingrown toenails. So you can develop ulcer, you can develop fungal infections. Diabetes can actually decrease your immune system so that you're more susceptible or sensitive to the developing fungal toenails, which is an opportunistic infection in your foot. Obviously, you can get fractures too if you can't feel your feet, you step awkwardly, you can develop Charcot. Diabetes can lead to neuropathy as well, so that's ingrown toenails. What is the number one modifiable risk factor to increase the risk of heart attack, stroke, amputation in the presence of diabetes? Somebody said it. But you can quit smoking, right? Some people can't, I think it's pretty addictive. So, any questions? 10-minute break? We'll do the next one and then we'll be done early. How's that sound?